So let me go to another central discussion issue of my talk, which can be summarized with a provocative statement. I would say, no matter what we do, either attributable death or years of life lost, we mislead and we distract from the relevant issues. Why that? To explain it, let me go to this lifetime model of the development of chronic states, of chronic diseases, which of course increase with age. So what we should not forget, mortality at the very end of people who develop these pathologies, these chronic pathologies, it comes at the very end, the mortality or the years of life lost. The state of health, however, is what matters. It is the time and this lifetime period that matters. It is health that matters. And it is health, or the reduced health, that ultimately determines our lifetime and our life expectancy. We are exposed over lifetime, and this exposure entertains the development of chronic pathologies, leading to lots of morbidities during lifetime and ultimately to premature death. We should invest far more in communicating that part of the air pollution-related adverse effects. However, to focus the risk assessment on morbidity requires an expansion of our methodologies and an in-depth discussion with economists as well, who continue to attach far higher monetary numbers to death. Also, we all know that part of this money is virtual, and also we know that the morbidity is far less monetized and less completely monetized, and sometimes even based on different methodologies. So we should emphasize what happens during life prior to death. But how should we do this in the risk assessment framework? So if I raise that question, let me discuss a third challenge we face. Very typical for many, if not all, chronic diseases, and certainly of those of interest in air pollution, is that those chronic pathologies are superimposed by acute exacerbations, acute problems. And now I see this slide got broken up by the device. Well, you have probably seen it before. There are peaks, immediate peaks, acute peaks that are superimposed as acute problems, superimposed on the underlying chronic pathologies. And I have shown the example of atherosclerosis as a long-term pathology and the superimposed triggered myocardial infarction. And the implication of this fundamental concept on the risk assessment is relevant, although it has not been much discussed. Sorry, let me go back. So this is the underlying pathology, and there are good animal studies now supporting strong evidence that air pollution contributes, at least in animals, to the development of atherosclerosis. And of course, air pollution epidemiology has shown strong evidence that air pollution can trigger these events among those with the underlying pathology. So to show you, to discuss the implication of this model, if we accept it, the implication on the risk assessment, let me go to another disease that actually follows a similar model, and this is asthma. Very similarly to cardiovascular disease, asthma consists in an underlying chronic pathology with superimposed events. Evidence of a causal role for air pollution for these events is very strong, and depending on how you read or term actually the evidence, you would even come to the conclusion that air pollution is likely also a contributing cause to the development of asthma. And I don't want to go into that discussion. You can go into these nice reviews, suggestive but not sufficient evidence, or others have concluded that there is consistent evidence for this statement. But if this is true, we have this model of acute and chronic effects, and this has implications on how we do the risk assessment, and I want to go into two major issues on that. I show you one example out of that literature. This is just one out of many studies. It is this smooth relationship between the prevalence of asthma and the proximity of how close you live to very busy roads. And this is the example from the Southern California Children Health Study. I use this one because we apply the risk assessment framework to this data. And this is the simplified dichotomous estimate of these relative risks. So those who live within 75 meters of very busy roads or highways had a 1.5 odds ratio relative risk, a 50% higher risk of presenting a prevalent case of asthma. So what we did with this data, we estimated the number of children living within 75 meters in Long Beach, and we applied this risk function to this population, assuming now, this new model, assuming that air pollution also causes the underlying prevalence of the disease. This has never been done in risk assessment so far, but if you apply these numbers, we did conclude that some 7% of the prevalence of asthma was attributable to air pollution in terms of living close to these busy roads. So this model raises now a provocative question. And let me expand this model. Traditionally, the asthma exacerbations attributable to pollution were quantified in one simple step, applied to the number of asthmatics in the population. However, if air pollution is, for some cases, the cause of the asthma development, we argue now that among those cases, one should attribute the entire box D, the entire future career as an asthmatic to air pollution, to living close to traffic. And this box, this fraction here, has never been considered at all in those risk assessments who assess the attributable cases of exacerbations of asthma. And if we don't do that, we would say this is a flaw, this is a consistent underestimation of the impact. So you may wonder whether this is an important difference or not. We did apply it to one outcome, bronchitis episodes, as a measure of these events. If you look into these numbers, this is the box D that we have added. So these are an additional 5% attributable cases that we would have ignored in past traditional approaches. So this is not a lot different. So this is, in fact, similar to the 33 total percent and 38. However, I have to tell you that in case of other outcomes, this can look very differently. And we went through this exercise and we applied the same concept also to emergency room visits. If we ignore this other underlying model of causality, long-term causality, emergency room visits are about 9 times larger, this impact. And this has to do with the frequency of these emergency room visits and with the risk function derived from the epidemiological literature. So I would argue it is very important how we apply the concept of chronic and acute effects in these diseases if air pollution contributes to both factors, and it has a major impact on the total impact attributed to air pollution. So let me summarize in terms of future needs in this business of risk derivation and communication. First, we need better strategies to communicate the years of life lost and the limitations of using attributable death. Second, we need to advance the risk assessment in the domain of morbidity. Third, air pollution consists in complex mixtures, and not all parts may be relevant for the same health effects, as discussed for the traffic proximity. So we need models that integrate all kinds of pollutants and their adverse effects. And last but not least, in case where pollution causes both chronic pathologies and its superimposed acute exacerbations, this must be integrated in the risk assessment framework, as we may grossly underestimate the overall impact if this is not done properly. Thank you very much.